All right, this is NR 602, Week 3, Lesson Section 1 on sports, physical pulmonary disorders, genitourinary disorders, and musculoskeletal disorders. The sports physical. Clearance to participate in sports is required in most states, with official examination and documentation forms often required state by state. The NP should be aware of local and state requirements, as well as access and keeping copies of all updated and needed forms for school and sports physical examinations. Begin with a complete medical history and include specific patient and family cardiovascular events and risk factors, including sudden death in family members at young or middle ages, previous injuries, including sprains and strains over the last several years, treatment and resolution or lingering disability, previous surgeries, any syncope, lightheadedness, or dizziness, recent weight loss or gain, regularity of periods for females and last known menstrual period. So LNMP, last known menstrual period. Current training or pre-season preparation for sports and general dietary habits or 24-hour diet recall. The sports physical should include a complete physical examination with Tanner staging, expanded cardiac assessment to include full evaluation for murmurs, some brief 1-minute exertion in the office, such as running in place, and repeat cardiac assessment, checking for peripheral pulse equality top to bottom and from left to right sides of the patient, including femoral pulses, testicular and inguinal hernia assessment in males, and an expanded musculoskeletal assessment. The musculoskeletal assessment must include the following. So the musculoskeletal assessment must include scoliosis screening, visualization of normal stance from anterior and posterior views with limb and spine positioning, noting knee alignment, valgus, verum, or pes plantus, full active range of motion of the neck, arms, and all lengths, leg joints, testing of muscle strength in the upper and lower extremities, and ability to squat, duck, walk forward, bend over, and touch the toes, and walk on heels and toes. So that was the assessment of the musculoskeletal system. So I pulled up some pictures on the terms valgus, varus, and pes planus that needs to be part of the musculoskeletal exam for the sports physicals. So with valgus, the feet are pointing outwards, whereas in varus, it's bow-leggedness. So valgus is described as a deformity involving oblique displacement of part of a limb away from the midline. So valgus is a deformity involving oblique displacement of part of a limb away from the midline. Valgus is a deformity involving oblique displacement of part of a limb away from the midline. Verum, or genu verum, is also called bow-leggedness, bandiness, bandy leg, and tibia vera. A varus deformity is marked by outward bowing at the knee. A varus deformity is marked by an outward bowing at the knee. A varus deformity is marked by an outward bowing at the knee, which means that the lower leg is angled inward or medially in relation to the thighs axis, giving the limb an overall appearance of an archer's bow. So that is verum. Genu verum is bow-leggedness. Genu verum, bow-leggedness. And then pes plantus is just flat foot. Pes planus is flat foot. Pes planus is flat foot. In anticipatory guidance related to the sports physical, heat exhaustion, dehydration, and injury prevention should be reviewed by the NP. Likewise, the NP should be aware that with growth velocity, i.e. the growth spurt, the risk for sports injury to growth plates increases, as does risk for sprains with an unstable joint. Next condition, pulmonary symptoms and diseases in children. Evaluation of common symptoms. Respiratory compromise and disease in children continues to be a leading cause of morbidity and mortality. Respiratory failure, particularly in young children, is a rapidly developing and ominous condition that requires immediate acute intervention. For the primary care provider, Recognition of respiratory symptoms in children, proper and prompt diagnosis, and recognition of impending respiratory failure are critical. Clinicians must be able to distinguish a croup-like cough from other coughs or inspiratory stridor from wheezing. Tachypnea is a critical sign that must not be mistaken in children. Knowledge of typical respiratory rates for infants, toddlers, and other school-aged groups is mandatory for any healthcare provider working with children. The combination of tachypnea with accessory muscle use, grunting, or nasal flaring should be a red flag to a provider that prompt and accurate acute care is needed. The healthcare provider should note oxygen saturation and obtain a full and complete history and full cardiopulmonary assessment on any child exhibiting tachypnea. Here is a video I found on a child with inspiratory stridor. The normal respiratory rate for infants less than 1 year age are 30 to 50 breaths per minute. So infants less than 1 year old should be breathing 30 to 50 breaths per minute. Infants less than 1 year old should be breathing 30 to 53 breaths per minute. For toddlers aged 1 to 2 years old, they should be breathing 22 to 37 breaths per minute. Toddlers ages 1 to 2 years old should be breathing 22 to 37 breaths per minute. Preschool-aged children aged 3 to 5 should be breathing 20 to 28 breaths per minute. Preschool children from 3 to 5 years old should be breathing 20 to 28 breaths per minute. School-aged children, which is 6 to 11 years old, should be breathing 8 to 25 breaths per minute. School-aged children from 6 to 11 should be breathing 8 to 25 breaths per minute. Adolescent children should be breathing adolescents are 12 to 15 years old. They should be breathing 12 to 20 breaths per minute. Adolescents are 12 to 15 years old, and they should be breathing 12 to 20 breaths per minute. This is an example of croup sounds. The description on the video says, sounds of croup from a 3-year-old with stridor during inhale, and they had to give epinephrine in the ER. Upper respiratory infection. Upper respiratory infections are some of the most common infectious diseases of childhood. Most often it's a viral infection of rhinovirus or coronaviruses. URIs often have a peak incidence in winter and spring months when communicability from indoor exposure is highest. Very young children often have an average of 6 to 7 URIs a year, lasting anywhere from a few days to a week. That sounds like something that might be on a quiz, so I'm going to say it again. Very young children often have an average of 6 to 7 URIs a year, lasting anywhere from a few days to a week. Common symptoms of URIs include congestion, sore throat, rhinorrhea, that can progress in color and amount as the URI progresses, but does not mean that bacterial sinusitis is present, and cough. Current treatment, particularly for young children, is hydration and over-the-counter antipyretics for low-grade fever or myalgia as directed by the provider. Normal saline rinse of the nares may be of some benefit in clearing congestion, but may not be well tolerated by some children. Complications of URIs include otitis media and sinusitis. Presumptive antibiotics should not be given to prevent these complications. Sinusitis in children cannot be diagnosed until at least 10 to 14 days. Sinusitis in children cannot be diagnosed until at least 10 to 14 days with lack of symptom improvement or development of new symptoms such as facial pain. Sinusitis in children cannot be diagnosed until at least 10 to 14 days with lack of symptom improvement or development of new symptoms such as facial pain. Children with asthma should be monitored for exacerbation and may need home monitoring of peak flow and symptoms or initiation of their asthma action plan for changes in the airway. Bronchiolitis. Bronchiolitis is a viral disease most often caused by respiratory syncytial virus or RSV, characterized by wheezing. So RSV is characterized by wheezing. So bronchiolitis is most often caused by RSV, which is characterized by wheezing. Bronchiolitis causes wheezing. Bronchiolitis often occurs in children less than 2 years of age. Other causes of bronchiolitis including influenza, parainfluenza, adenoviruses, and rhinoviruses. Some rare bacteria can on occasion cause bronchiolitis, such as Mycoplasma pneumoniae. These diseases are highly contagious and spread through droplet transmission. Children with lung disease, prematurity, immunocompromised, or those in daycare are at higher risk of contracting the illness. Symptoms follow several days of incubation and begin with URI-like symptoms, progressing to worsening cough, rhinorrhea, and wheezing. In infants and young children, irritability may also be present. Upon exam, these children may also show increased work of breathing, prolonged expiration, grunting, intercostal retractions, and nasal flaring. Lung sounds may include wheezing and crackles. Bronchiolitis can present with or lead to pneumonia. Bronchiolitis can present with or lead to pneumonia. In patients who present with symptoms of respiratory distress, pulse oximetry measurement, and anterior, posterior, and lateral chest radiographs, a full cardiopulmonary assessment is advised. So if they're in respiratory distress, a full cardiopulmonary assessment is advised. Treatment is purely supportive for RSV or bronchiolitis and includes monitoring of pulse oximetry, oxygen, hydration, nutrition, and frequent observation. Croup. Croup is also known as laryngotracheobronchitis. Croup is also known as laryngotracheobronchitis. Croup is also known as laryngotracheobronchitis. It is caused by a viral infection of the middle respiratory tract, which includes the larynx and bronchial tree. So croup affects the middle respiratory tract, which includes the larynx and the bronchial tree, creating the classic symptoms of a barking-like cough. Symptoms include none to low-grade fever, URI symptoms, and a barking cough. Inspiratory stridor can occur and will manifest as obstruction to the airway worsens, leading to progressively worse symptoms of respiratory distress. Wheezing may also be present if there is any involvement of the lower airway. Diagnosis of croup is primarily made on symptoms, but a chest radiograph that includes the neck can rule out pneumonia and show subglottic narrowing known as steeple sign. Steeple sign is a subglottic narrowing, and it is characteristic of croup. Here is an x-ray of a normal airway, and then this is steeple sign. So you can see here that the airway, there we go. The airway goes, you can see all the way up, it's open, whereas with a patient with croup and steeple sign, it gets narrow and narrow, so it looks like a steeple on a church. Treatment of croup is supportive and aimed at alleviating symptoms. Glucocorticoids such as dexamethasone 0.6 mg per kilogram to 1 mg per kilogram intramuscularly or orally will assist in reducing airway swelling and improve symptoms. In acute cases with respiratory distress, aerosolized racemic epinephrine will reduce swelling in the larynx and subglottic regions. Like bronchiolitis, pneumonia can be a complication, and patients should be closely monitored. My preceptor and I saw a patient with croup this past week, and he recommended cold, humid air. Next condition is pneumonia. Pneumonia can occur at any age group and is always a significant diagnosis. For younger or immunocompromised patients, the risk of developing pneumonia is significant. Symptoms vary based on age group. Where neonates may have no symptoms of pneumonia other than fever, irritability, or lethargy, older children typically manifest with pneumonia with a cough, fever, tachypnea, and obvious illness. However, insidious symptoms in children are not uncommon, including complaints of abdominal discomfort and nausea or vomiting. As pneumonia symptoms progress, all children exhibit signs of respiratory distress that must be managed quickly. Common causes of pneumonia and thus treatment vary by age group. The NP should be aware of common bacterial and viral causes of pneumonia by age group. Evaluation of pulse oximetry and respiratory status, as well as education for parents who may manage mild cases at home on what progressing signs and symptoms should prompt seeking immediate acute care, should always be included in the evaluation and plan of the care for children with pneumonia. Proper knowledge of appropriate antibiotic medications for bacterial causes, dose, route, frequency, and duration, as well as risks, is critical for the NP. I've got a couple of questions on pneumonia from APEA from the practice exams that I want to review. It says a 6-year-old child who has moderate persistent asthma is diagnosed with pneumonia after chest x-ray and laboratory studies. He developed a sudden onset of fever with chills. He is in no distress. What is the preferred treatment for him? So this is for a 6-year-old who has moderate persistent asthma and is diagnosed with pneumonia. And the answer is amoxicillin. So amoxicillin for a 6-year-old with pneumonia. A healthy 7-year-old child is diagnosed with atypical pneumonia. He is febrile but not in distress. What is the preferred treatment for him? The answer is azithromycin. In this age group, so if a child is greater than 5 years old, the most common atypical pathogens are mycoplasma or chlamydophilia. Therefore, a macrolide antibiotic like azithromycin is a preferred agent. It is usually chosen first for its coverage of atypical pathogens. Doxycycline is not an appropriate choice because it is contraindicated in children younger than 8. However, it does provide coverage against atypical pathogens. Amoxicillin provides no coverage of atypical pathogens, so it is a safer choice. A 6-year-old being treated for a community-acquired pneumonia, or CAP, has been taking azithromycin in therapeutic doses for 72 hours. His temperature has gone from 102 degrees Fahrenheit to 101 degrees Fahrenheit. What should be done? The answer is to change antibiotics to a penicillin. Rationale is that a 6-year-old with community-acquired pneumonia should show improvement in symptoms in 24 to 48 hours if he's on the appropriate antibiotic therapy. Azithromycin treats atypical pathogens like mycoplasma and chlamydia, but has poor strep coverage. The most likely pathogen in this age group that causes pneumonia is an atypical pathogen, but at this point the most common typical pathogen, strep pneumoniae, must be considered. The best choice to consider strep as the pathogen and treat with a penicillin. Specifically, this patient should receive a high-dose amoxicillin because of the increased incidence of resistant strep pneumo. The most common cause of pneumonia in an otherwise healthy 3-year-old is a viral infection. The most common cause of pneumonia in an otherwise healthy 3-year-old is a viral infection. The rationale is, in children who are 6 months to 5 years of age, the most common cause of pneumonia is a viral pathogen. I'll say that again. Children who are 6 months old to 5 years of age, the most common cause of pneumonia is a viral pathogen. The most common cause of pneumonia between 6 months and 5 years of age is a viral pathogen. From 6 months old to 5 years of age, the most common cause of pneumonia is a viral pathogen. Rarely are studies performed to identify viral pathogens. However, one of the most common viral pathogens is respiratory syncytial virus, or RSV. S. pneumonia is a common cause of pneumonia in very young children, so less than 6 months of old. It is also implicated in older adults as a causative agent in pneumonia. In young and middle adults, mycoplasma is a common pathogen. Week 3, lesson section 2. Genitourinary symptoms and diseases in children. The genitourinary system in children. The genitourinary tract begins development as early as the 4th week of pregnancy, and urine formation begins at the end of the first trimester of pregnancy, creating amniotic fluid. By about 9 weeks gestation, the kidneys can be found in their adult location in the upper abdomen. When gathering data on a child who may be suspected of renal or urinary problems, be sure to note the following. History. Concerns urinating timing, color, frequency, amount, abdominal pain, and other associated or systemic symptoms. Physical exam. Cardiac, abdominal, circulatory, and neurological systems, along with assessment of hydration status. Laboratory testing to consider with genitourinary system in children. Urinalysis for specific gravity, RBCs, WBCs, nitrates, protein, leukoesterase, and pH, BUN, and serum creatinine. A 24-hour urine creatinine if needed. Lower and upper urinary tract infections in children. Urinary tract infections occur more frequently in girls, 8% to 2% comparatively, although uncircumcised male infants less than 3 months of age are at risk. Uncircumcised male infants less than 3 months of age are at risk for UTI development. Uncircumcised male infants less than 3 months of age are at risk for UTIs. Lower UTIs are considered uncomplicated and involve the bladder or urethra. Upper UTIs include the kidneys and are complicated, requiring hospitalization for fluid stabilization, rapid treatment, and monitoring for sepsis. Risks for development of UTI come with perineal irritation from soaps, bubble baths, and wipes. Parents should be educated on limiting bubble baths in young girls and on front-to-back wiping after toileting. In girls who have more than 2 UTIs, no matter the span in childhood, evaluation by urology is encouraged. In boys who have 1 or more UTIs, evaluation by urology is encouraged. So if girls have 2 UTIs, they should go to urology, but boys only need to have 1 to go to urology. Common symptoms in infants of UTIs include fever or hypothermia, jaundice, poor feeding, irritability, vomiting, failure to thrive, sepsis, or strong-smelling urine. Common pediatric UTI symptoms include abdominal or flank pain, urinary frequency, dysuria, urgency, and uresis, vomiting, and fever in complex or upper UTIs. Any child with fever with UTI should be considered to have a complicated UTI. Any child with a fever should be considered to have a complicated UTI. Any child with fever and UTI should be considered to have a complicated UTI. Laboratory testing should include urinalysis, urine culture, and sensitivity, gram stain, and laboratory values for hydration and electrolyte balance. Proper collection of a urinary sample in an infant or young child with a true clean catch may be difficult. The provider may need to consider in and out catheterization in the office to achieve the best specimen. In menstruating females, this may also be the best way to get the most accurate specimen, particularly if the child is acutely ill and accurate and timely diagnosis is critical. The most common organisms causing UTIs are E. coli in more than 85% of the cases, followed by Klebsiella, Proteus, Enterococcus, Staphylococcus, and Streptococcus. Treatment depends on culture, child's age, and current antibiotic guidelines. Proteinuria. Urine protein is not rare, particularly in children and adolescents who are active. Some metabolic states increase the risk of proteinuria, including exercise, fever, and starvation. There can be chronic and genetic diseases that contribute, so proteinuria should never be taken lightly, particularly in light of other contributory symptoms. Be sure to read your text on proteinuria for specifics in differentials, laboratory testing, and further evaluation. Hematuria and glomerulonephritis. True hematuria is not a normal finding in a child and should warrant further testing. Keep in mind that if a young girl is menstruating that she may have RBCs in the urine. Hematuria can be gross or microscopic. A thorough history, medications, recent illnesses, and associated symptoms are important to gather with hematuria. Your text includes further discussion of important notations of hematuria. Glomerulonephritis is a finding that should not be missed in evaluating hematuria and occurs due to renal insult. So glomerulonephritis is caused by renal insult and is created by immunoglobulin damage to the kidneys. There are several types, including post-infection glomerulonephritis, membranoproliferative glomerulonephritis, IgA nephropathy that causes glomerulonephritis, Henoch-Schönlein purpura, or HSP, Systemic lupus can cause glomerulonephritis, and Alport syndrome, which is a genetic condition, can cause glomerulonephritis. Acute post-streptococcal glomerulonephritis followed by infection is the most common type, occurring 10 to 14 days post-streptococcal infection. Wow. So acute post-streptococcal glomerulonephritis following infection is the most common type of glomerulonephritis, and it occurs 10 to 14 days after streptococcal infection. Acute post-streptococcal glomerulonephritis occurs 10 to 14 days after streptococcal infection. Acute post-streptococcal glomerulonephritis results in edema, renal insufficiency, and dark tea-colored urine. HSP, or the Henoch-Schölling purpura, is the most common cause of small vessel vasculitis in children ages 2 to 7 years and begins with itching, urticaria, and progresses to a maculopapular rash with purpura on the legs, buttocks, and elbows. HSP, or Henoch-Schölling purpura, can also come with joint pain and has renal involvement in as many as 50% of the cases. Be sure to read your text concerning evaluation of hematuria. Wilms tumor. This is also called nephroblastoma. Wilms tumor or nephroblastoma accounts for 90% of childhood malignancies. Wilms tumor or nephroblastoma accounts for 90% of childhood malignancies that arise from the urogenital tract. Wilms tumor typically presents as an abdominal mass. Approximately 80% of children present this way. So Wilms tumor typically presents with an abdominal mass with or without associated abdominal pain or hematuria. As you study this condition, remember to review etiology, epidemiology, signs and symptoms, diagnostic criteria, treatment, and prognosis. Week 3 lesson, section 3, musculoskeletal symptoms and diseases in children. Musculoskeletal complaints and injury in children, while common, are frequently benign. For the nurse practitioner, it's important to note significant variations that warrant immediate attention. As in adults, fractures, strains, and sprains present with similar symptoms. However, young children with musculoskeletal complaints of the lower extremities may refuse to ambulate altogether in an effort to avoid pain. Below is a list of both common and important musculoskeletal complaints in children that the NP should be able to define and recognize symptomology for. I do want to mention I saw a patient this past week in urgent pediatric care who had an injury and was refusing to walk. She was 3 years old, and the pediatrician told me that that's actually less common, that the younger children have a really high tolerance to pain and they might just limp around, but to completely refuse to walk, in her experience, was less likely. Okay, so we've got a list of both common and important musculoskeletal complaints in children. This includes soft tissue trauma, sprains and strains, fractures of the lower and upper extremities, leg calf perths, Osgood-Schlatter disease, scoliosis, slipped capital femoral epiphysis, genu valgum and genu varum, nursemaid's elbow and other dislocations, boxer's fractures, jammed fingers or joints, recognition of more serious conditions, including osteomyelitis, neoplasms of the bones, and juvenile rheumatoid arthritis. Imaging. For the nurse practitioner, both radiographic imaging through X-ray and magnetic resonance imaging MRI will help to confirm many diagnoses. MRI always follows initial X-ray screening and has the benefit of no radiation production. Additional laboratory procedures are always warranted in children with fever or additional systemic symptoms associated with their musculoskeletal complaint. The Society for Pediatric Radiology has an important Image Gently campaign that you should be aware of. Information on the goal of reducing radiation exposure in children can be found at the organization's website. Week 3 lesson, section 4, abdominal pain and GI diseases. Important pediatric considerations. To begin understanding the gastrointestinal and genitourinary concerns in children, it is important to keep in mind the importance of hydrating in children. Fluid and electrolyte balance, regulated in large part by these two systems, is critical to pediatric well-being. The total body water of infants and children is greater than in adults. The total body water of infants and children is greater than adults, and dehydration is a leading cause of death in children globally, primarily due to gastrointestinal disease. Please be aware of the signs and symptoms of dehydration in children and the importance of electrolyte balance. See PowerPoint presentation in this section to assist you in increasing your understanding. And this is the PowerPoint, fluid needs and dehydration in children. Fluid and electrolytes regulation. Total body water, or TBW, is 50 to 75% of total body mass. There is less total body water, or TBW, for obese people, so they can become dehydrated quickly. There's more total body water for infants, so they can become dehydrated quickly. ICF, ECF, major electrolytes of plasma, sodium bicarbonate, protein albumin. Importance on labs to note osmolality to diagnose an imbalance. ADH secreted in water loss for renal conservation of water is triggered at 280 milliosmoles per kilogram. Thirst is not physiologically stimulated until osmolality reaches 290 MOSM per kilogram. Goal of fluid replacement is providing maintenance, replenish prior losses, replace persisting losses. Osmolality, or osmotic activity per weight, and osmolarity. Osmolarity is the measurement of osmotic activity per volume of solution. Osmolality is osmotic activity per weight, and osmolarity is measure of osmotic activity per volume of solution. And this measures oncotic pressure. Basics of IV therapy in children who will be prolonged NP and even adults. It is to understand the short-term needs of water, glucose, and electrolytes needed for the goal. If IV therapy is going to be short, the patient will probably have enough kilocalories on board and will provide some injury through ketosis, and can provide 20% of normal caloric needs. Fluid and electrolytes regulation. 1 milliliter of water is needed for each kilocal expended. So 1 milliliter of water is needed for each kilocal expended. Water to kilocalories is 1:1. Water needs and caloric needs per unit of body weight in 24 hours. Body weight in kilogram, 3 to 10 kilograms needs 100 kilocalories per kilogram. And so they would need 100 mils of water per kilogram. If the body weight is between 11 and 20 kilograms, they will need 1,000 kilocalories per 50 plus 50 kilocalories per kilogram for each kilogram over 10 kilograms. And the formulation for the amount of water is the same. If the body weight in kilograms is greater than 20, they will need 1,500 kilocalories plus 20 kilocalories per kilogram for each kilogram over 20. With the same formula for water. And it looks like they go over some of those formulas. The most common problem in clinical pediatrics is dehydration, and GI disease is the common culprit. Infants and young children at higher risk. Infants and toddlers have the highest ratio of surface area to weight, so there's more body loss through evaporation. Dehydration. Clinical history, fluid intake, frequency, amount of vomiting, diarrhea, urine output, or number of wet diapers in 24 hours, duration or degree of fever, types of medications, or underlying disease. Need not only ill weight, but last normal body weight. Accuracy of office weights is critical. The physical exam for dehydration is the vital signs, heart rate, capillary refill, dryness of lips, mucous membranes, lack of tears, lack of external jugular venous filling when supine, sunken fontanelle, oliguria, and altered mental status. And these signs warrant immediate attention. Alterations in disease or body that increase your fluid requirements. So the general requirements are 1 mil per 1, what were the units? It was just 1 to 1. I can't remember what it was. Anyway, so something that would increase this is a fever, 12% for every degree of Celsius. So you need 12% more water for every degree of Celsius above normal that you have. Hyperventilation will increase fluid requirements by 10 to 60. Sweating increases by 10 to 25 milliliters per kilogram. Hyperthyroidism, 20 to 50%. I'm not sure what that means. So list GI and renal disease, clinical signs, and degree of dehydration. If there's 3 to 5% body weight loss, would be mild dehydration. If there's 6 to 10% body weight loss, it's moderate dehydration. And if there's 11 to 15% weight loss, it's severe dehydration. Turgor, if it's normal, it's mild dehydration. If it's decreased, it's moderate dehydration. If it's markedly decreased, it's severe dehydration. If the pulse is normal, it's mild dehydration. If it's slightly increased, it's moderate dehydration. If there's tachycardia, it's severe dehydration. If the capillary refill is 2 to 3 seconds, it's mild dehydration. If it's 3 to 4 seconds, it's moderate dehydration. If it's greater than 4 seconds, it's severe dehydration. If tears are absent, there is severe dehydration. Mild oliguria and anuria are how you classify urinary output. Electrolyte needs for maintenance. 3 to 4 milliequivalents of sodium plus 100 kilocalories. 30 to 40 milliequivalents sodium per liter. No hypotonic fluids to prevent hyponatremia. So when you're giving IV fluids, or I guess even oral fluids for electrolyte needs, you don't want the fluid to be hypotonic. Electrolyte compositions of body fluids, and it shows how much you lose with diarrhea and in gastric. Small intestine sodium concentration, otherwise similar potassium and bicarbonate. The GI tract. The GI tract is a series of hollow organs from mouth to anus that serve as the mechanism for nutrients and fluids to enter into the body system for use and wastes to be removed. The mouth serves as a place for chopping food, lubricating, and initiating carbohydrate and fat digestion. The esophagus connects mouth to stomach, where food is stored for brief periods, but where digestion really increases and food is turned into a liquid for movement into the small intestine and throughout the remainder of the GI tract. To be able to absorb foods, chemicals are needed. Any disruption in anatomy Any disruption in anatomy or the chemicals needed for digestion will result in disease. Any disruption in anatomy or the chemicals needed for digestion will result in disease, whether from invader, injury, or generics. GERD. GERD is most common in young infants for anatomical reasons, but can be present in any age group. It is important to read up on the disease and current national guidelines. In infants, spitting up is a common occurrence and can happen frequently after meals. It's important for the clinician to differentiate between physiological spitting and GERD. Please read the article below for more information. GERD, Management Guidance for the Pediatrician. Abstract. Recent comprehensive guidelines developed define the common entities of GERD as a physiological passage of gastric contents from the esophagus and gastroesophageal reflux disease, as reflux associated with troublesome symptoms or complications. The ability to distinguish between GER or gastroesophageal reflux and GERD is increasingly important to implement best practices in the management of acid reflux in patients across all pediatric age groups, as children with GERD may benefit from further evaluation and treatment, whereas conservative recommendations are the only indicated therapies in those with uncomplicated physiologic reflux. This clinical report endorses the rigorous, developed, well-referenced guidelines. A key issue in distinguishing between clinical manifestations of GER and GERD in term infants, children, and adolescents is to identify patients who can be managed with conservative treatments by the pediatrician and to refer patients who require consultation with the gastroenterologist. Accordingly, the evidence base is, lifestyle changes are emphasized as first-line therapy for both GER and GERD, whereas medications are explicitly indicated only for patients with GERD. Surgical therapies are reserved for children with intractable symptoms or who are at risk for lifetime-threatening complications of GERD. Let's go to... If there's chronic heartburn... Actually, I'm not going to read this. Foreign bodies. Foreign body ingestion, just like findings in the nose or ear, is common to pediatric populations. Ingestion of non-food foreign bodies into the mouth and subsequent swallowing is more common in children exploring their environment with their mouths and hands. Coins are the most common culprit. A large number of these pass without problem, but 10 to 20% require surgical management. Signs and symptoms of concern include dysphagia, odynophagia, drooling, regurgitation, abdominal pain, and difficulty breathing. The ingestion does not have to be witnessed. Narrow areas of the GI tract are common places of larger foreign bodies being lodged, like the thoracic inlet, the pylorus, and the ileocecal junction. When diagnosing foreign bodies in the GI tract, avoid contrast studies to keep the patient NPO. Note that if a foreign body is sharp or is lodged, it must come out to prevent trauma and erosion. Other important GI diseases. And they list a bunch to look up. This includes acute abdominal pain, chronic abdominal pain, constipation, diarrhea, encoparesis, hernias, intussusception, pyloric stenosis, ringworms, viral gastroenteritis, and vomiting. And that's all of the text lessons for this week.